This is part 2 of the discussion on fourth generation photodynamic therapy. As we discussed in the first session, the real trick to this is having the perfect sensitizer. How do we know that it's perfect? Well, first off, it has to have the ability to locate and go into the diseased tissue and avoid the healthy tissue. Things that are commonly in use, like that was the first one that was approved in the United States, that goes about 3 times as much into diseased tissue as it does healthy tissue. Consequently, it's activated by sunlight or even incandescent bulbs. Once you've had an injection of that, you cannot have any exposure to light at all for at least 2 weeks, no exposure to actual sunlight for 4 weeks or longer. If you are exposed to sun, you can wind up with actual third-degree burns and wind up in the hospital. That doesn't happen with our sensitizer. There are other sensitizers that do somewhat better, like chlorin E6, and there's a variety of variations of the chlorin E6. Those are a little bit better, but they only go 6 times as much in the diseased tissue as into the healthy tissue. So, although it's an improvement, it's still not good enough to actually treat cancer from outside the body. The molecule that you use for a sensitizer has to be able to combine with both oils and water. So it's what they call an amphiphilic molecule. Most of the ones that are used are either lipophilic or hydrophilic, and that causes a disaster when you try to actually treat somebody deep inside the body. They also need to have a positive charge because the cancer cells has a negative charge. When you get a positive charge sensitizer, it's attracted to the cancer like a Star Wars tractor beam. The really critical part is what wavelength is this activated by. Most of the sensitizers out there are activated by 635 nanometers, which is kind of an orangish red color. The problem is that won't penetrate into the body very far. The next generation, what they call second generation sensitizers, are activated by 660 nanometers. Now that does penetrate a little bit further, but it has a big self-shielding problem because there's so much of it in the healthy tissue. And the sensitizer that's in the healthy tissue absorbs the light before it gets to the diseased tissue. That factor is what they call the absorption spectrum versus bioabsorption. Ideally, it should be 680 to 690 nanometers. Our sensitizer activates at 685 nanometers, so it's in the perfect range for being able to penetrate deeply into the body. The other factor is intracellular targeting. Once this sensitizer gets into the cell, where does it go? It can hang around in the cell wall. It can go to any of the organelles inside the cell. Ideally, you want it in the mitochondria. Our sensitizer, aluminum phthalocyanide, when it first goes in, it's attached inside the cell. Within 15 seconds after being hit by a laser, it releases and goes to the mitochondria. So it's essentially perfect on that. The efficiency, that's how much of the reactive oxygen species do you get per watt per second, is actually very important. Ours is 75%. Some of the others run in the range of 35%. Rapid clearance from healthy tissue. Well, our sensitizer doesn't go into healthy tissue that much, but after we finish treatment, we give a very simple organic material, and that removes all of it from the body within a matter of a couple of days. And so we can put the person back on the street. They actually are walking around in midday tropical sun as long as they wear long-sleeved shirts and a hat immediately after getting the sensitizer. So we've solved the problem of sun sensitivity. In the next segment, we'll discuss exactly how this is done.